Okay, let's get started on part 2 of infancy. We left off on language development, so I'll pull that back up and we'll get started. All right, language development. Nonverbal, primarily, of course, at the beginning. Smiling for the first 3 to 5 weeks. Crying, that's their first means of communication. By 5 to 6 weeks, they should vocalize by making what we call small throaty sounds. Now, some parents will swear that the small throaty sounds are them saying daddy, mama, goo goo, gaga, whatever. But really, they are just what they said, small throaty sounds. At 2 months, they make single vowel sounds, 3 to 4 months, they make more consonant sounds and start cooing and gurgling and squealing and laughing a lot. The thing you need to take note of is the infant who does not display a social smile by age 8 to 12 weeks needs further evaluation. Something's not right and there is a developmental delay. By 4 to 6 months, they are babbling a lot. By 8 months, they're adding more constant sounds and combination syllables, dada, mama. 9 to 10 months, they are obeying simple commands and understanding the word no. So if you start to spat that hand and say no, depending on what tone you say it in and what type of temperament the child is, you may get some crocodile tears. 10 to 11 months, they ascribe meaning to their words, such as mama and dada. So you thought they were having a good time, knew who mama and dada was earlier, but according to the famous theorist and developmental psychologists, they don't know that until around age 10 to 11 months. 12 months, they can say 3 to 5 words with meaning. Okay. Now, we know with the acquisition of new learning skills and language skills that they may temporarily give up their recently learned sounds and words. This is kind of distressing to some parents who've waited and waited for them to say mama or dada, and now they've quit saying it for a while, but they will come back around. They're just learning some new words. Play. Play is very important during this time. Play, solitary mainly, where pleasure is demonstrated by a quieting attitude at 1 month, at 2 months a smile, and at 3 months a squeal. If you'll remember, this was called social affective play. Pleasure now demonstrated more by interaction during play when they need more rattlers and bouncies and rockers. Remember, that was sensory pleasure play, 3 to 6 months. And then play demonstrated by more sophisticated play and involves sensory motor skills, such as their peekaboo and patty cake, is called skill play, and that is common around 6 to 12 months. All right, suggested activities for infants. There's a lot where it talks about play. On page 322, it talks about some of the play and the various suggestions for stimulation for play during the infancy period. Now, one of the things you need to remember is they need to be played with, not merely allowed to play. So these infants want to be played with and cuddled and also given some attention. So you want to make sure that you're paying attention to playing with them. Stuffed animals. What about stuffed animals? Well, if they're going to use stuffed animals, we need to be sure and look at the animal itself. They don't need eyes that are easily removed or any other part of the face, a nose or anything that can come off easily because they may actually swallow those. Also, cleanliness. You want to make sure they're staying clean. Metallic mirrors. A lot of people, I had that on the test one year and someone thought that meant a metal mirror. Metallic mirrors are those mirrors that have the shiny stuff in them that they can see themselves, and they are quite safe during this time. All right, attachment. Parenting is not an instinctual ability. I wish it was, but it's a learned, acquired process, and some things you learn the hard way. But basically, there's 2 components of cognitive development that's required for attachment to occur. One is the infant has to be able to discriminate the caregiver from everyone else. And then has to have the achievement of object permanence. They have to know once they leave the room, they're coming back for me. And if you'll remember, that develops at around 6 to 8 months. Are you seeing a pattern? There's 4 stages of attachment. The first few weeks, the infant will actually respond indiscriminately to anyone. That's why when they're little, you can pass them around about anybody. Then beginning at about 8 to 12 weeks, they start crying and smiling and vocalizing more for that person who's been their primary caregivers. At 6 months, they start showing a distinct preference for one or the other. And at 7 months, they start attaching to other family members. So that's kind of the 4 stages of attachment that they go through. As far as separation anxiety, and I think I was having a brain infarct when I did these page numbers, but it's actually page 321, and that's where it talks about the RAD too, 321. This is a sign of a healthy parent-child attachment. It is most prominent between 6 to 8 months. Separation anxiety develops in a predictable sequence. At around 6 months, the infant protests when left in the crib. At 7 months, they protest when the caregiver leaves. And by 11 to 12 months, the infant is able to anticipate their departure, watching for the clues, and begins to protest before they leave. They get smart. They realize, hey, they're packing up, they're backing up slowly. This means they're leaving. Wah! Right? If you look on page 321 in your book, again, very sorry about that, you'll see reactive attachment disorder. This is a psychological or developmental problem that stems from maladaptive or absent attachment between the infant and parent and may persist into childhood and even adulthood. Infants at risk for RAD include those who have been victims of physical and sexual abuse or neglect. Infants exposed to parental alcoholism, mental illness, substance abuse, and infants who have experienced the absence of a consistent caregiver as a result of foster care, institutionalization, abandonment. RAD is a form of extreme insecure attachment. Historically, 2 different patterns of RAD were described. The emotionally withdrawn, which inhibited the pattern, and indiscriminate, inhibited pattern. And recently have proposed, though, that now 2 subtypes also exist for this disorder. Now, all I want you to know is what we've already talked about. So look over that again on page 321. Stranger fear. This is most prominent ages 6 to 8 months. As the infant demonstrates attachment to one person, they correspondingly exhibit less friendliness to another. This is related to their ability to discriminate, and it's manifested by crying, clinging to the parent, and turning away from strangers. And when was it most prominent? 6 to 8 months. This can be a negative impact as well as a positive part of growing up, because if you allow them to continue to have stranger fear throughout, then it will get to where close relatives and friends cannot even, they're not even comfortable with them holding them, and then they don't want the parents going anywhere, and they want you to be with them at all times and cling to you so that you can't have your date night or anything else. All right, so what's the best approach to a stranger for a child this age? Well, the best approach is to talk softly to the parents, maintain a safe distance from the infant, and avoid gestures like running in and holding out your arms and screaming, "Come here, sweet pea," at the eye level. Most of the time, you will get a big "wah" in return. You have scared the daylights out of them. Parents need to be reassured that stranger fear and separation anxiety are healthy. They are desirable. This is necessary for this infant to have optimum emotional development. But it is something that you can also help them get through. It can be accomplished by swiftly, yet with care, love, and emphasis on the parent's return. It is normal also for an infant to be fussy about the same time each day, and they say they're expending their energies and emotions of the day. They're kind of letting it all out. Now, if they do this excessively for several hours in a day, then we are worried about colic. Infants' temperaments. Let's see here, page 322 and page 70. I actually got these page right. Actually talks about the infant temperaments, and this is by Thomas and Chest, and he identified 3 common patterns of child temperament. He said there's the easy child, the difficult child, and the slow to warm up child. I wish I was Thomas and Chest. they got a lot of money for the easy, difficult, and slow to warm up child. Now, they have revised that just a little bit. And the way that you tell what your child is the parent takes a 95-question questionnaire related to sleeping patterns, feeding patterns, playing patterns, and dressing patterns. And that will at the end display, depending on how much you answered in certain areas, what type of temperament your child is. And of course, by temperament, we mean their behavioral style, or how rather than the what or the why of their behavior. So you can read over that. So looking at the easy child, most of us wish we had the easy child, but actually 40% of us do. These are even-tempered, they work well and play well with others, they have a regular, predictable pattern in their habits. If you approach them with new stimuli, they're going to be positive. They are very open to change and usually overall in a positive mood. Your difficult children, which are 10%, and if you've ever had a difficult child, you know how difficult it can be. They're highly active and irritable. They're irregular in their patterns. They require structure. They react very negative to change. They are slow to new routines, usually a negative mood, and frequent crying and temper tantrums. Nurses can assess the temperament of young children and alter their environment then to meet these needs. If you have a difficult child, then putting them in the room with an easy child may be distressing on the other parent. Whereas if you have two difficult children in the room, that may be distressing as well. But it is something you want to keep in mind when you're doing room assignments. Last but not least is the slow to warm up child, about 15%. They react negatively with only mild intensity to new stimuli. They adapt slowly with repeated contact. So they warm up, it just takes them a little bit. They're kind of quiet and inactive and just a little bit moody. They respond with mild but passive resistance to change and only mildly irregular in their patterns. So they're in between the difficult and the easy child. Now, they do say about 35% of your children can be combos, a little bit of both. There is what's called the goodness of fit, or the degree of fit theory that you need to read up in your book. And what this is talking about as far as the nursing role is your child rearing as well. Because if you have a parent who has expectations, hey, my child, I want easy children. I want it to be easy going. They're going to do what I say. Everything's going to be good because I'm an easy parent and I am a type B and laid back. Probably a good fit then. But if you have a very type A personality as a parent and you are gifted with a difficult child, then sometimes the goodness of fit theory isn't quite there, the degree of fit therapy. But there is child rearing practices related to a child's temperament and based upon their temperament. And I want you to read that on page 323. And we all know that there's different degrees. Infant sleep patterns. At birth to 3 months, 10 to 16 hours, they're going to be out, with about 5 sleep periods of 30 minutes to 3 hours at a time. 3 to 6 months, they're sleeping still about 14 to 15 hours daily, with longer sleep at night and 2 to 3 naps per day. 6 to 12 months, they should be sleeping 12 to 14 hours, with longer sleeps at night and 1 to 2 naps daily. Don't forget, parents need adequate sleep as well. Some things that can help with this if you're having a child that's having trouble sleeping is placing the baby to sleep in a quiet and darkened room. Having the similar bedtime routines. They like routine. Provide a consistent transitional object, such as a favorite blanket. Put the child to bed while still awake rather than after falling asleep. Do not try to awaken the baby in non-REM. Establish a regular sleep routine and time. And remember again, it's normal for infants to be fussy about the same time every day. But if they are doing this consecutively all through the night, being fussy during the day, then you want to think about colic. Nutrition, it's during infancy that eating processes form a primarily reflective activity to becoming a very sophisticated yet messy attempt at self-feeding. For the first 6 months, of course, human milk is our most desirable, Everyone is pushing breastfeeding these days because it contains all the nutrients the infant will need except iron at 4 to 6 months. Cereals can help with this issue. Solid foods are not recommended before 4 to 6 months. Solid foods are not recommended before 4 to 6 months. Now, there are people who want to tell you different. Feed those babies. I fed my baby mashed potatoes at 3 months, they'll say, and they did just fine. Well, we have more children with constipation than we've ever had, or have been seen with constipation than ever before. And part of that reason is introduction of foods into the diet before the stomach is ready for it. Microwaving breast milk, advantages of breast milk. There's some alerts on page 327 in your book that you need to read over. So please read your nursing alerts. Express milk is good up to 5 days when you're breastfeeding, refrigerated and frozen up to 10 months. Now, of course, an acceptable alternative is our iron-fortified formulas. The amount of formula and the number of feedings per day is going to vary from infant to infant. 6 feedings at 1 month to 4 to 5 by the 6 months of age. The infant is just not developmentally ready for solid foods, though. Okay. Now, there's also an alert on page 326 for you to look at, and it's talking about vitamin D. Okay, so look at that alert as well. For the second 6 months, well, if we had the American Academy of Pediatrics wish, we'd all still be breastfeeding or formula feeding. But most of us start feeding solid foods anywhere between 4 to 6 months in the form of cereals. And then at 6 months to 12 months, we progress to our baby foods. Fluoride supplement is needed 6 months to 3 years, particularly if the water is not fluoride. Watch toothpaste. It has a lot of fluoride in it, too much for the infant. A major change in feeding habits is the addition again of solid foods. And now the infant is physiologically and developmentally ready because the gut has become better prepared to handle more complex nutrients. Too much fluoride can also discolor the teeth, so you want to be careful about that. Tooth eruptions beginning, so you want to make sure that you're watching the teeth. That extrusion reflex has disappeared, so they're able to eat better. That's that tongue constantly sticking out. Swallowing is more sophisticated and coordinated now. Head control should be well developed by 6 months. Remember that. Head lag should be gone. Voluntary grasping and improved hand-eye coordination. Now they don't just hand regard. They understand they can reach that hand down there and bring it forward. So what sequence do we introduce new foods? The first foods are infant cereals, is usually rice-based, and we usually mix that with breast milk or formula. After introducing fruit juices, these may be mixed with cereals at 6 months. Here's your common sequence: cereals 4 to 6, strained fruits 6 to 8, strained veggies 6 to 8, meats 8 to 10, and eggs and cheeses 12 and over. Now, if you look here in your 6 to 8, strained fruits and veggies, I would feed the strained veggies first. Because if you've got a jar of sweet potatoes versus Tutti Frutti, and they get a liking for the Tutti Frutti, they're not going to eat your veggies. So make sure that you are doing that and getting their veggies down before they eat just fruits. Why rice when we're talking about the cereal? Well, with rice, it's easy to digest, but it also has low allergenic potential. And iron is needed during this time, and it has a lot of iron, not ion. It has iron. Juices 4 to 6 months, and it talks about not heating those in the microwave because you kill the vitamin C when you heat them, so do not heat. At 6 months, finger foods are liked. At 8 to 9 months, junior foods, primarily your cooked foods. And by 1 year, well-cooked table foods. As far as introducing new foods, some of the rules is you want to introduce solids when the infant's hungry. Spoon feeding by pushing food to the back of the tongue because some of them, they still want to spit it out some. Using a small spoon with a straight handle. You want to begin with 1 to 2 teaspoons of food at a time. And introduce each new food at 4 to 7 days interval to allow each food time to see if they have an allergy to it. As solid foods increase, milk should decrease. They should be able to drink from a cup by 9 to 12 months of age. So by 12 months, they should be on a sippy cup. Weaning can be very difficult. That's relinquishing the breast or bottle for a cup, and it occurs around 8 to 9 months and by 1 year. There's no one best time to do it, and weaning should be gradual. The last feeding to be discontinued should be the nighttime one. Now, there's games that you can play with this, going down, let's throw away all of our bottles and open up the treasure chest, and wow, the pirates left us something special, and it's full of sippy cups. I mean, you can make it a little bit more fun. If breastfeeding has to be terminated before 5 to 6 months, then weaning should be to a bottle. If it's later than that, if you have to quit breastfeeding, let's say at 8 months, then you should try to go directly to a sippy cup. Nutritional counseling, commercial versus home prepared, does it matter? Do you have to buy Gerber's? Can you make it at home and mash it up? And the answer is absolutely. Just be prepared and be careful that when you're doing that at home, on your having moderation of your salt and sugar content. Now, we don't use honey because of the risk of what's called infant botulism. We know that honey is not sterilized, so it contains Clostridium botulism spores. And infants are unable to detoxify these spores, and they can end up with what's called infant botulism. We'll talk about that later on in GI, but trust me, you do not want your child to get that. The most prevalent nutritional disorder right now is overeating, not only in adults, but in children too. Now, you've got to understand there are some cultures that value that. They think a fat baby is a healthy baby. So you have to look at the cultures when you're considering that. Early childhood nursing caries, it talks about that a little bit in your book. And there's a nursing, let's see. And it is in page 426. I don't know what I was thinking when I did this. I think I was having a brain infarct. Let's see. Hold on just a minute because I'm going to find that. It shows you how to brush their teeth starting on page 394. Sorry about that. 394. I think I was having a TIA when I did this. Transit idiot attack. It shows you there as we start, of course, for little ones, we can help, and that is the most effective way for us to clean when they get about a year of age is by holding them. It talks about, on page 395, nursing tips to encourage the child to open their mouth and tweet like a bird or say cheese, and that will help to sing and tell stories while we brush our teeth. The fluoride supplement is there on page 395. And if you look on 396, that's where the nursing carriers are located. On 396, it talks about early childhood caries, and you can see there that you can actually rotten out the mouth. Now, be very careful about this because some children have disorders, genetic disorders that affect their teeth, and they cannot help it. But this is caused by usually laying down the child with a bottle of something kind of sweet substances at night or during nap times. So you do not want to do that because their mouth could end up looking like this. Do not substitute skim or low-fat milk for the older infant because the essential fatty acids are inadequate and the concentration of protein electrolytes is too high, as in sodium. As far as dental care, pediatric dentists, the first visits, they should be around 6 months of age, no later than 1 year. You want to wipe them off with gauze or a damp cloth or just a small brush after feeding up to the age of 1 year. All right, what about thumb sucking? Well, in general, there's no need to restrain non-nutritive sucking during infancy. Malocclusion will only occur if it persists past 4 years of age because your permanent teeth are erupting. So after age 4, if they're still doing it, we really need to look for the source. Is it boredom? Is it isolation? Lack of stimulation? Why are they doing it? Security? For most children, thumb sucking reaches its peak at 18 to 20 months as a rule. I remember when my sister was breaking her child from thumb sucking. She tried everything that she could. And there's all kinds, there's guards you can put on it. There's medicine you can put on it. And some of these kids will still hide and do it. Usually, again, if you start trying to figure out the source of the problem, then it can be corrected. But just so that you know, there is an adult thumb sucking website that people get together. All right, immunizations. This is an important part of your lecture, and knowing the immunization schedule is very, very important. Sorry, flipping over. It starts talking about those on page 331 in your book, a little bit on page 330. It talks about a little bit about those, and then it gets on over about even those who fall behind and how to do the catch-up schedule. You will not have to know the catch-up schedule. You will only have to know the regular schedule. Their immune systems are immature, so they really, really do need some type of immunizations to protect them. So the immunization schedule itself in your books on page 332, but I have also posted the immunization schedule to help you. The way that I have posted it is by age, so that it's a little easier to remember. And you need to know this inside, outside, upside down. Whether you know my handout or you know this page, you're going to have to know, because I may ask. Here's an example of how I may ask it. A 2-month-old comes to the clinic today. Which of the following immunizations would you expect to give? Select all that apply. And I will have several listed, and you would have to know which ones to give and select those. Okay? Or I may ask, a 2-month-old and a 4-month-old are receiving immunizations today. Which immunizations would the 2-month-old receive that the 4-month-old would not receive? And the only answer is hepatitis B. Other than that, they're getting the very same thing. So you have got to memorize this. Also, there's a legend down there. So it tells you what each one of those stand for. It talks about some of the newer medications, the Menectra. It talks about influenza is annually from 6 months of age on. And as long as someone's allergic to eggs, that doesn't necessarily mean they can't have some of these. They have to have an anaphylactical reaction to eggs. Now, if they've had that, then of course they would not get any of the immunizations that are egg-based. Most of these are dead. There are a few of these that are alive, like the MMR, the varicella, the nasal influenza. So some of these you want to be very careful about. Also, with most of these immunizations, a lot of them, the stopper still has latex in them, so you want to be very careful to make sure that you're not using that. For the most part, they have quit using mercury as a base because of all of the accusations of the problems that it has caused. So I want you to know this chart inside, outside, upside down. They also have combinations, Pediarex, which is a combination of your DTP, your diphtheria, tetanus, and pertussis, along with your Hep B and your inactivated polio all in one. So it's 3 for the price of 1. Well, not price, but for the sake of getting 3 different shots, you're getting them in one single shot. Just some other things you should know about pertussis. It's not given to children over age of 7. Risk of vaccines outweigh the risk of the disease. Controversy regarding neurological problems is given before age of 6 months. Now, for preterms, they need to stay on their schedule with all of these full doses. And it talks about each one of these in the book as well. MMR, you need to know if they have allergic response to neomycin. This would be a contraindication. A history of allergy to eggs, chickens, or chicken feathers is not a contraindication for receiving the MMR unless it's an anaphylactical reaction. Side effects can be anywhere from anorexia, malaise, rash, and fever up to 7 to 10 days after immunization, and some pain in the joints. Now, 59% of all children less than 2 are immunized. That means we still have a whole lot that are not immunized. So there is a reason for that. They can't take this second series until after 12 months. So actually, they can't take any series. They can't take even the first one. So they have to be 12 months and older before they can get their first MMR. And so if they have taken, if you're getting ready and you have a child who is 11 months old when they got their first MMR and they've come back for their second MMR, they cannot get it. That will only count as their first because they got their first dose before 12 months. Varicella chickenpox, children ages 12 to 18 months, single dose, given sub-Q. MMR is given sub-Q. Age 12 to 18 months with a booster at 4 to 6 years, and do not vaccinate if they have a positive history of varicella. So if they've had chickenpox, whether it be 1 or 2 or 10,000, it seems like, they do not get the varicella. For an adult, it's 2 doses, 4 to 8 weeks apart, and it can be given with other vaccines such as MMR and varicella combination vaccines. Takes about 6 weeks to build immunity, and some children may develop a mild varicella rash during this time. Some may develop a low-grade fever, and there's no evidence of loss of immunity. In 10 years, no booster needed. Now, most of your places have went back and said, hold on, hold on, hold on. I still would rather someone have immunity, so that some places are requiring that they have 2 varicellas now. Polio, there's 2 forms. We know we don't see polio anymore, but there's the Sabin and the Salk, and you need to know the difference. The Sabin is the oral type, but the oral type has the live vaccine, and so the disadvantage is that it has actually caused some vaccine-associated paralysis. The Salk, the advantage is it is the inactivated polio vaccine, so it has no history of causing any vaccine-related paralysis because it is the dead virus. But the disadvantage is that it's given sub-Q and requires boosters for immunity, so you have to have several shots. A lot of you had this when you had the sugar cubes when you were growing up. Hib, Haemophilus influenza. This provides protection against a number of serious infections caused by Haemophilus influenza, especially meningitis, bacterial epiglottitis, bacterial pneumonia, and sepsis. Now, it's not associated with the flu, and it can be given in combination with DPT. Children under 2 who develop the Hib-related illnesses, let's say they developed one of these, epiglottitis, they still need to be immunized because it can help fight against these others as well. Reactions that are common. Side effects most common to occur within a few days or hours after administration include, and common reactions are, redness, soreness, swelling at the site, fever, and behavioral changes such as irritability. Pertussis may be associated with more serious reactions such as loss of consciousness, convulsions, thrombocytopenia, and fever greater than 105. Contraindications for all immunizations would be a moderate or severe illness with or without fever, or the presence of a minor illness is not a contraindication, such as the common cold. So if they have a common cold, they can still get their immunizations. If they have a moderate or severe illness, they cannot. Live viruses are not given to anyone with an altered immune system because the multiplication of the virus can be enhanced, and that would cause a more severe vaccine-induced illness. Of course, anaphylactic reactions to anything is a contraindication. Presence of recently acquired passive immunity, including blood transfusions and immune globulin, is a contraindication. If you've had one of these, administration of live vaccines should be postponed for 3 months after passive immunity. So if you've had a child who's had a blood transfusion or an immune globulin transfusion, they need to wait 3 full months before they have a live vaccine. Pregnancy is a known contraindication to immunization against MMR and should not be given to anyone likely to become pregnant within 3 months. A known allergic response to a previously administered vaccine, such as pertussis or a substance in it, of course, is a contraindication. A reaction to Baker's yeast and vitamin and hepatitis B would be a contraindication. DTP, if you've had encephalopathy within the last 7 days, of course, you wouldn't want to get the DTP. Inactivated polio, if you've had a reaction to neomycin or streptomycin because it's a base in it. MMR, pregnancies, immunodeficiencies. Varicella, neomycin, gelatins, corticosteroids are contraindications. So there are several contraindications. Documentation. Be familiar with the manufacturer's directions. The month, day, and year should be documented. The name and address and title of the person giving it. The site and route. That you've had informed consent. And that if they've had any adverse reactions, that a report has been filed. Okay. Page 340 talks about atraumatic care of giving all immunizations. And of course, they're all given IM except the MMR, the varicella, and the MMRV, which is the MMR plus the varicella together, and the form of the meningococcal. The influenza, the live is intranasal, and the oral for rotavirus, everything else is sub-Q. So make sure that you read over that chart on page 340 about atraumatic care, and that you also read on page 342 about the order of injections. And down at the bottom there, evidence-based practice that goes over the appropriate site, technique, needle size, and we're not going to worry so much about the dosage at this point. All right. Don't worry, there's more to come. I'll cover injury prevention later on, so you do not have to worry about that being on this test. Again, I apologize that my page numbers was off a little bit. Not so sure there, other than the instructor may be off a little bit. LOL. All right. I hope this helps. If you need anything else, let me know. Thank you.